which you want to say. So don't jump immediately to the obvious finding. So I would read this as this is a contrast radiograph of the part of the head and neck, then go chest and upper abdomen. It is an oblique view. It is not even a P or an AP view because you can see asymmetry of the chest ribs on either side.
Yes.
And then it's taken with a purpose to be oblique so that you can look at the esophagus. Otherwise, you wouldn't be able to see the esophagus and the airway separately if you wanted to. And there is contrast, which is filling a pouch which looks like an upper esophageal pouch. It is just anterior to the spine. And then you have the airway also filling. You can identify it with the bronchial tree. So if you say all this, and then you say the rest of what is seen is normal, then the examiner will go on to ask you questions. So why do you think this is a upper pouch fistula, like you are saying? You said this looks like a fistula, isn't it? Upper pouch fistula
Yeah.
somewhere there. Why do you
Yes,
think
sir.
this is a fistula? Why is this
Because
not
contrast
something else?
is seen in the it can be normal aspiration also, sir, when doing
Yes.
oral contrast study.
Yes.
But they were
Yes.
close to each other, abutting. That is why I felt, but less chance of upper pouch
Okay.
fistula.
So how would you say that this is aspiration or fistula from this picture? Tell me.
Because airway is seen right from the level of
From
larynx,
here
sir.
onwards, the airway
Yes, sir.
is seen.
Upper
As
airway
dense,
is seen.
yeah, as dense here and as dense there. So which means it's more likely to be
Oral aspiration, sir, rather
Yeah.
than
What is the other reason why this is likely to be aspiration rather than an upper pouch fistula? One more reason.
dysmotility, sir. Like dysmotility, pharyngeal dysmotility, because of some neurological.
No. Anything about the size of this pouch? When there is an upper
Diabetic.
pouch fistula, the pouch is usually small.
Yes, sir. It is not
The pouch
dilated.
is small because it is decompressing into the airway, isn't it? That
Yes,
is one
sir.
of the features. So that is why this is unlikely to be an upper pouch fistula. It's more likely to be an aspiration because of these two
Aspiration.
reasons. Yeah. So that
Okay,
is why
sir.
you must justify what you're saying. Right. So what precautions do
Okay,
you
sir.
take when you go to do this contrast study to the radiology suite? What precautions do you take? How do you prepare and go?
Sir, I'll make sure there is intubation tray and there is suction apparatus working.
Yes. Correct.
And
Right. What else?
head propped up position of the baby.
Okay.
And one assistant with me, sir.
Oxygenation. Right. Oxygen, and
oxygen.
Importantly, there must be light there. Radiology suits are all dark. So there must be light there for you to do all these procedures when you do.
Necessity.
And what is the position of the child when you do this test?
Propped up position, sir.
Yeah,
Supine
slightly
with propped up position.
So all these are simple measures, but they're important in salvaging the child and getting it back alive to the ward should such an incident happen. Right.
Yes, sir.
So would you do this study? Suppose you want to do. Actually, there is no need to do this study for a diagnosis. So whatever it is. So if it was you had to do a study, would you do it with barium, thin barium, or would you do it with water soluble contrast?
Sir, I'll go with water soluble contrast, sir.
Why?
Even if aspiration happens again, barium can cause this chemical pneumonitis. So
okay, barium pneumonitis is worse. But what is the problem with water soluble contrast pneumonitis? Does that cause something? Does that cause something very typical? Barium pneumonitis, like barium peritonitis, is a very purulent sort of inflammation. What will this cause? Okay, this is hyperosmolar. It draws a lot of edema and it causes a typical pulmonary edema.
okay, sir.
Right? Oh, fine. So you see from where the questions went to where. It depends how you lead. That is how the questions will go, and that will sort of tell the examiner how much you know. Okay.
Okay, sir.
So read into the radiograph what it shows. Don't read more than what it shows. Okay, good. Right. We'll
Okay.
go on to the next one. Sujay, you are there. Sujay, are you there? Okay, fine. Who's taking this? Neha, Shravya? Neha, Shravya, any exam going person, please come forward. I don't have to call you. Come.
Dr. Neha.
Who's this?
Hello, am I audible?
Yes, you're
Sir
audible.
Neha.
Who is this?
Okay. Sir, Neha from Nayan
Neha.
Hospital.
Okay.
I'm the
Go
third
ahead,
year
Neha.
exam going PGR math.
Go ahead,
Sir,
Neha.
this is a special
Be
diet.
loud, be loud.
Okay. This is a special diet study. Uh, Special dye study, sir, an X-ray X-ray dye study, a contrast study, taken in the AP position.
Sorry.
This shows
Yeah.
the
We are not able to hear properly what you're saying. Come closer and speak loudly.
upper pouch, and the dye, there is a sudden cutoff with beaking, and then the contrast is going into. Okay, so this is a special contrast dye study of the upper GI tract taken in the AP position, where we can see that the dye is trickling into a dilated upper esophagus, is in the dilated upper esophagus. There's a sudden cutoff, slight bleeding, and then the dye trickling into the stomach.
I think she's connections are not okay. Okay, and anyone else wants to take this? I think her phone connection is probably not okay.
Hello,
So
sir,
what
this
is
is
the dye?
Shravya. Hello.
Yeah, Shravya, go ahead.
Yes, sir. Sir, this is a dye study wherein we can see a dilated esophagus along with beaking distally.
Yeah, sorry.
We
Okay.
can see. Okay.
So I think there's a problem with the.
Hello. Yeah. We
Go
can
ahead,
see
go
that
ahead,
the dye is
Shravya.
reaching the. Yes, sir. We can see that the dye is reaching the stomach. So it's this could be achalasia cardia based on the findings. Yes, sir.
Okay, so you think this is achalasia, right?
Yes, sir.
Why
One
is
possible.
this not lower esophageal stricture?
So the characteristic dilatation along with beaking is suggestive of achalasia cardia. So the stricture would have something like an apple core appearance, wherein we can see the shouldering.
Okay, it may not have an apple core appearance, but you are right that it will not be a smooth taper like this. It will
Yes,
be
sir.
a much more acute sort of taper, a proper taper. This is a very smooth dilatation and a narrow tape beaking which is seen. There you will
Yes.
not find a beak because the lower esophagus, if it is stricture, depending on the etiology, it is going to look quite different.
Yes, sir.
Okay. What are the lower esophageal strictures you have seen?
So lower esophageal strictures.
Common ones which you have seen or we find in children. One or two common ones.
So stricture would be. So I've not seen any stricture as such.
Corrosives?
Yes, a corrosive poisoning would be.
Okay, corrosive is one. One more?
The post re
Yes,
I don't know, post regurg reflux or
reflux. Yes. So GER stricture. So you should
GRDS.
not, yeah, you always think of common things and say. So those are two common ones that we see.
Yes, sir.
Right. So what is this area on the top? Is this a narrowing? Is this a narrowing there?
So I wouldn't call it a narrowing. It's just comparatively, it's a normal caliber as compared to the distal part of the esophagus.
Why is it looking so narrow? Only so much.
So it could be a so the peristalsis.
Okay. You can see contrast there, lining
Yes,
there,
sir. Yes, sir.
right? So this is a sort of air pocket there, like a double contrast.
Okay.
That is why
Yes,
it is
sir.
looking like this.
Okay.
And there's one layer sort of thing there also.
Yes,
So
sir.
it's just that it is looking, it's not that it's any narrow, it is as wide there.
Correct. Yes,
Omega
sir.
esophagus, right?
Yes, sir. Yes,
So
sir.
tell us how do you manage this?
So if it is a case of achalasia cardia, so we go for so there's medical management and surgical management. So firstly, so surgically, there's cardiomyotomy, Heller's cardiomyotomy that is done. Then
So what
so
is the
none of
medical management?
so starting the child on antacids, then so then
What did you say? Medical management?
the antacids, then
Acha, okay.
along with that, so for the dilatation, there
Okay,
are two.
dilatation. So dilatation is one form of management which is done. How successful is dilatation in managing this vis-a-vis cardiomyotomy?
So it is associated with recurrence or
Okay.
higher
So
rate of
you
recurrence.
must know those figures if you're going to
Figures,
say
yes, sir.
dilatation. If you don't mention dilatation, you say the management is surgical, which is fairly standard. It is
Yes, sir.
okay. Or
Okay,
in
sir.
this thing, if you say endoscopic dilatation, then you must be ready to say the number of times it has to be done and what is the success rate, etc.
Yes, sir.
Right. So, is this prone to any complications? This when you do this contrast study?
So one is aspiration,
Yeah.
so, and so apart from aspiration,
That is probably the predominant complication
yes, sir.
that you
Yes, sir.
can. Okay, right. We'll go on to the next picture. Okay. Who's taking this? Yes, please.
Mm.
Yeah, one of the exam going people, please take this. Come on, volunteer and take. I can see Dipanjan there. Is Dipanjan finished exams? Anish?
No, sir. No.
Yes.
So,
Come on, take this.
sir, is it inverted mushroom sign or
You have to describe. Don't ask the examiner questions. Come, describe. Go ahead and describe.
It's from Shravya's phone. My network was giving a problem.
Yeah, you want to take this?
Yeah, can I take it, sir?
Please take. You are?
Sir, Neha.
Neha, right. Your network was not okay. Now it's
Yes.
okay. Come, take.
So this is a special contrast dye study, which is an X-ray, AP, chest and abdomen, where
Yeah.
we can see dye entering the stomach. The stomach appears to be dilated, followed by which there is a constriction at the pylorus. The antrum appears a little bit more prominent, and there is no contrast which is going distal to this constriction. So it could be a gastric outlet obstruction.
Okay. What are the possibilities. Where do you get something else? You have to tell me. What about this?
The G junction is
Okay, maybe on the fluoro you can see better that there is reflux also, right? So there is some obstruction there, and then there is this reflux. So what do you think? This is a 3-year-old, as you can see, 3-year-old child. What are the possibilities? Where do you get such a scenario? 3-year-old, a gastric outlet obstruction. Is it a complete obstruction or is it an incomplete obstruction?
since it's a late presentation, so it could be an incomplete obstruction. At
Yeah,
3 years
and
of
also
age, I
you
would
are
not
saying
expect
air distally, isn't it?
distally, right?
Yeah, so you say this is incomplete because of that, right? So what are the possibilities?
Could it be a duodenal web with a central perforation presenting
Okay,
late?
that is one possibility. Okay, but this
Could be
is it in the duodenum? You
no,
only
sir.
said that it's in the gastric outlet.
A pyloric web
Yeah, okay, fine. Then what else?
could be a stricture because of
Yes, could be a
poison
corrosive stricture
or
also.
a stricture.
Right. So suppose I tell you this was a child with an ingested corrosive. So
Right.
how would you proceed to investigate this child and manage this child?
I would firstly
It
like to
was
go
a
for
child with a corrosive.
upper GI endoscopy, sir, to know the level of obstruction.
Why do you want to do an upper GI endoscopy? This child has a history of corrosive ingestion, and you have done this contrast study, and you find that it looks like an obstruction there with very little going down. So what will upper GI endoscopy additionally help?
Just confirming the diagnosis to see the caliber of the okay.
Must justify. I would say that if you want to do an upper GI endoscopy, it would be to especially look at the
G
esophagus.
junction.
You want to
Esophagus.
see the esophagus, and then at the same time, of course, you can see this. But will it help in as a therapeutic measure?
No,
Or
sir.
just a diagnostic measure?
Just diagnosis.
Just diagnostic measure. Could it help if as a therapeutic measure elsewhere?
If it's at the G junction, then yes, we can do
Yeah.
a dilatation, a
Yeah.
stenting
So
of
if
the
it's in the
stricture, but
esophagus, yeah, if it's in the esophagus, it might help you. So open your mind when you're answering these questions so that they know that you're thinking on practical lines.
right.
Okay. So you've done a scopy and you find that there's a narrowing there. You're barely able to put anything across. So what is your management? What will you do?
I will have to bypass this obstruction, so I could go for a gastrojejunostomy.
Okay. You must say what you do. So have you seen corrosives, which pyloric strictures
No, sir, I
you
haven't.
manage with gastrojejunostomy? Is that a common thing which is done in children?
No, sir, I actually
What do you
haven't.
do in your center? You should say what you've done.
A pyloroplasty.
Yeah, but in an acute situation, you may not be able to do the definitive procedure if you're talking of pyloroplasty.
Right.
In a child who is not nutritionally well,
A
would you
feeding
do a
jejunostomy.
pyloroplasty?
I would.
Yeah, so you might do a feeding procedure like a jejunostomy and then later come back to do a pyloroplasty. If you do a gastrojejunostomy in your center, fine, you say that. Be ready for questions on gastrojejunostomy because that is not a favored surgical option in children compared to adults. So you must be ready for questions there.
Okay, sir.
Or if you say that you do a feeding jejunostomy or you give TPN, then you come back to do the thing, it's fine. Both are acceptable. So most of the time we do a feeding procedure and then come back. So is it important? Suppose you have a larger, much of this is also burnt out and you have a small stomach and so much of long stricture is there. What are your other options? What do you do? what do you do? Suppose you have a small stomach like that. Very small stomach here, so much. And then all this is fractured. So you will do a feeding jejunostomy, right? Anything else? Is there a chance that this might grow, or you have no option? Because later you want to do a pyloroplasty here.
Right. I'm sorry, sir. I don't know the answer actually.
Okay, so if you it is such questions are asked, if you answer the initial ones and they want to see if you can extend your surgical knowledge, etc., and go further on. So if you have lost part of this, basically we want to know if it's possible to mobilize this and like a Billroth one do something, or you will need a replacement like a Roux-en-Y jejunostomy, or you will do gastrojejunostomy. All those things are unusual things. But if you begin starting sort of exploring those answers and saying, then they know that yes, you know how to troubleshoot and move out of that, and you know the pros and cons.
Right.
Never mind. Okay, so we go on to the next. Yes. Bhanu?
Good evening, sir. Hello.
Bhanu, Dipanjan. Come on, anyone take this. You don't have to be
Sir, good
shy
evening,
of
sir.
taking the. Yeah,
Keshav here, sir.
go ahead. Go
This
ahead.
is a
Keshav, go ahead.
yes, sir. This is a contrast follow through, sir. Contrast meal follow through. Shows dilated stomach and duodenum up to around D2 D3 junction with contrast entering the distal small bowel loops which appear normal.
Yes.
Not able to clearly see the spine, sir, to comment on the side of the
Okay.
BJ flexor. So
Fine.
it could be a
So you are looking at the spine to comment on malrotation, right?
yes, sir.
Acha, okay. But does this look to you like malrotation, this sort of a dilatation?
No, sir, it's a rounded this one, sir.
Yeah.
So no
Yeah.
beaking.
So what does it look to you like?
So mostly a perforated duodenal web, sir.
Okay, yeah, it's more probably that a web diaphragm, etc. there with a central hole. So, which do you know of some of these conditions where you find something like this? Some genetic conditions?
Down syndrome, sir.
Trisomy, yes. This child also had trisomy. So, how would you manage this intraoperatively?
First, I would like to like palpate for any site of obstruction, sir, if any web is palpable. Otherwise, I would.
What do you want to palpate for? You have opened the abdomen, you find this large thing which is there. What is it that you want to palpate for?
I would like to know the origin of the web, sir, where attachment into the bowel is.
Okay, so that is what you wanted to palpate for. I thought you wanted to palpate for something else. So what are the things that can cause an obstruction there at D2, like you said?
Annular pancreas.
Malrotation is one you said.
Annular pancreas.
Annular pancreas. Okay, fine. So you might find a ring of pancreas there. Then what else? When you were saying about this hole, how do you identify this hole?
Sir, we can do an enterotomy and pass a Foley's and fill the balloon, hitch it to see
Where
the
will you do the enterotomy? Here in the duodenum?
No, stomach side, sir.
You'll do in the stomach, put in a Foley's and then inflate
Hitch up
and
to
withdraw.
see the
Or if you have, can you put something per oral, per nasal
whatever
also?
NG tube is there, which can pass it and confirm.
NG tube is difficult to inflate and all. If you have something
sir.
else, you can put in like a Fogarty, etc. long
sir,
one
yes.
which will go there and you can inflate it and pull it and see where it is indenting and open there.
Yes.
Okay. Right. So, what are the common anomalies associated here besides besides this annular pancreas? What are the other anomalies which can be associated here? You said annular pancreas, you said malrotation, because this is an
Duodenal
embryology crossroad. You know that.
Yes, sir.
What are the other things which may be associated here?
The SMA syndrome, sir, the duodenal obstruction secondary to.
Okay, yes, a little distally. Then you can have anomalies of the biliary tree and pancreas also.
Yes, sir.
They can also be associated. Right, fine. Good. You go on to the next person. Who's taking this? Yes. Chandrika, Deepak, Shweta.
So, Shravya here.
Yes, Shravya, go ahead.
So this is a dye study with a barium follow through. So we can see that the DJ is lying to the right
You
of the
say
spine.
contrast because you don't know whether
Contrast.
they've used
It is a
barium or
follow
you
through.
just say
Yes, sir.
contrast.
Yes,
Yes.
sir. It's a contrast study wherein we can see that the DJ is lying to the right of the spine, which is
So has this child swallowed it or how?
so this is through the Riles tube it has been given to the
Yeah, you
child.
can see that tube there. Okay,
Yes, sir.
right.
Yes, sir. So it goes in favor of malrotation, sir.
Why?
So because the DJ is to the right of the spine.
Yeah, it's almost on and to the right of the spine. Okay,
Yes, sir.
fine. So how do you go about doing the study in the radiology suit? You put in the contrast, you see it is not going, it is all there in the stomach, but you know that this should go, it's still not going. What do you do? You have done the study, right?
Yes, sir.
So tell me, how would you do? You put enough into that NG. In fact, one of the reasons why we use that NG is so that you don't have to go on giving that fellow things to drink, and then he
Correct.
also finds it difficult.
Yes, sir.
Okay.
So we initially take a scout, followed by after which we give the dye, and once the dye
What is
is
your
given,
scout show? What
So
will your
in this-
scout show in malrotation? Since
firstly-
you mentioned it.
so it could be a gasless abdomen in if it is associated with a volvulus.
Okay, yeah.
Then apart from that, and if it is
Normally,
not
what will
associated
the
with a
scout
volvulus,
show? It might show a dilated stomach and a little in the duodenum, but distally
sir,
you
yes,
won't find much of air.
any dilated. Correct. Yes, sir.
Right. Or
Yes,
whatever
sir.
little air you find, it might be towards one side rather than all
Throughout.
around.
Yes, sir. Yes, sir.
If you have an NG tube in place, then and child is on aspiration, it may not show the dilated stomach also.
Correct. Yes, sir.
Right. So in
Yes,
this question, when the examiner asks,
Hmm.
he's
Yes, sir.
seeing whether you can explore different possibilities and tell the answers accordingly.
Okay.
Right. So you must be able to say that. Right.
Yes, sir.
Fine. So you put in the contrast.
Yeah.
Now it's not going. What do you do?
Yes, sir. So
You have to
I
picture
will.
the DJ. It's not going.
So I'll repeat an X-ray in 15 minutes.
No. You are there in the contrast suit. It's not going down. Are there maneuvers which we do for it to go across? Just like in paracholecystography, it's not going
Yes,
up.
sir.
We put a clamp below, put head low,
Yes, sir.
and then we see whether it's going up. Same way here.
Okay. So we could give a lateral position.
Okay, you can turn the patient to the
Side.
right.
Yes, sir.
It should go. If it still doesn't go,
So propped up.
propped up, no.
Okay.
Prone. You turn the
Okay.
patient prone. Yes. Then it usually goes. Haven't you seen the radiologists do it? It
No,
goes
sir.
down.
Okay.
And then you can see your DJ thing. Basically, you want to see the position of the DJ. That is what will
DJ,
give you the
yes, sir.
diagnosis.
Yes,
Right.
sir.
So you turn to the right and you can turn prone and you see whether it is going down or not. And
Correct. Okay, sir.
do you put what? How is this different from a usual upper GI contrast study? Barium meal follow through or contrast follow through. Is it like a follow through? Very often
No,
you see
sir.
films with how is it different?
So this is more like a swallow that we do, and then under fluoroscopy we assess the.
Correct. You want to see the upper bowel only. You
Yes,
want to
sir.
see the DJ. So you can't
sir.
instill a whole lot of contrast and flood it. If you flood it, you will see bowel loops all over the place, whatever goes
And
down
then-
contrast, and you won't be able to know the DJ. So that
Yes,
is why, as you can see, this is one film, and in the very next film, we have seen the DJ.
Yes, sir. Yes, sir.
Right. So that is the technique of doing this.
Okay.
Right. What are the components of this procedure, large procedure?
So firstly, so if it is associated with the volvulus, the first step would be derotating the volvulus, followed
Okay.
by releasing the latch bands, then
Okay.
straightening the duodenum,
Okay.
widening the mesentery, inversion appendicectomy, and placing the bowel in non-rotated position after ruling out any other causes of obstruction.
Okay. Is this particular procedure prone to some complications? Large procedure, common complication.
Adhesive obstruction after
Adhesive
releasing.
obstruction, very typical. Common
Very good.
complication.
Very good. Mm.
Yeah. Where else is this large name used? Another one or two, do you know?
So there is a so lads so lads so there's a lot
Are
of
there
places
some large
lads is with
criteria?
so lads criteria.
Duplication, you have some large criteria?
So I'm not aware of lads
Okay,
criteria. I
so
know
that is
that
another
lads has
common
done a lot of.
question asked.
3-4 criteria are in to diagnose duplications.
Yeah, so large criteria. Where else do you have large? One or two names you should know. You know, Dennis Brown, Lard, these are great personalities. Their names are used in so many places. So one or two things you should know
Okay, sir.
about the difference. It's just a trick question that the examiner might want you to ask. Okay. Go ahead. Next.
Sir, can I take this, sir?
Please.
This is a contrast study cholangiogram, sir. Showing dilated cystic.
What cholangiogram is this?
Mostly a percutaneous cholangiogram, so you can see a tube here.
Achha. Okay. Percutaneous cholangiogram in the choledochal cyst.
Could also
ECOG
be
cholangiogram we do,
ERCP, sir.
yes.
ERCP also, if you can see a endoscope.
ERCP, you will have something going
Endoscope you
down
can see.
from
Yes.
here. You will see one thing and all.
Yes,
Can you
sir.
see something there?
Yes, a tube you can see.
This is a tube. Unusual. In some particular case, they have put in a tube there and they're doing like a T-tube cholangiogram. Something like that. Very unusual situation. Okay, go ahead.
Yes. So we can see a mildly dilated intrahepatic radicals, sir, and partially distended gallbladder and dilated cystic lesion in the CBD, sir.
Right.
And no contrast seen entering the bowel.
Okay. What else are you seeing?
Yes, sir. That could be a pancreatic duct.
Yes. Why are you saying it is pancreatic duct?
The location and the direction of the.
What is the course of the pancreatic duct?
It on the left side will be horizontal, so it turns downwards and joins the
Okay, it
Is it
goes
doctor?
across the L1 spine, then it goes up there cranially in an angle, and then across L1 spine, and then it comes down and joins
Downwards.
at
Major papilla.
ampulla L2, etc. So you can say that. So that is how you identify this is the
Yes.
duct, pancreatic duct. Right. So this was a patient, obviously, in whom they have put a T-tube.
Tube.
Probably, what are the situations where you might want to put a T-tube like this?
When there is cholangitis and to buy time, previously they used to
Okay.
keep a tube
You
and
can't do a PTBD, etc. Something. Other situation is intraoperatively they have realized that it is a bad thing and they can't go ahead with the definitive surgery and they have put a T-tube. It's a very unusual situation. That
yes.
was the situation that this patient came from another place with a T-tube. Right. So, what is your standard treatment for this?
Choledochal cyst excision with the hepaticoduodenostomy or a hepaticojejunostomy, sir.
Okay, so you know the comparison between the two. What is more and what?
Yes, sir.
That's another stock question.
Yes,
So
sir.
can you summarize hepaticojejunostomy versus hepaticoduodenostomy?
Yes, sir. So the incidence of cholangitis is comparatively lesser in hepaticojejunostomy, sir, because there is a rule
Okay.
which prevents, and
Okay.
chances of bile reflux is more in hepaticoduodenostomy.
Okay. Right. What about stricture?
Stricture, not sure, sir.
Stricture is more in a jejunostomy or a duodenostomy? Okay. What about access? Endoscopic access. That is one of the supposed advantages for duodenostomy. No? Should there be a narrowing, you have good endoscopic access.
Yes, sir.
Yeah, whereas endoscopic access with the jejunostomy is a difficulty. So this is one standard thing which you must know. Hepaticojejunostomy versus, and now there are enough studies to show that they are all very comparable and not much of a difference. But these are the plus and minus. It's very much like comparing your Soave, Swenson, and Duhamel for thing, or the gastric transposition tube, etc. in esophageal replacement. So you must know these are very standard questions.
Yes, sir.
Right. We go on to the next. Yes, this is an interesting one. Who's taking this? Some volunteers. A newborn presented, newborn means 20 days, presented with distended abdomen.
So it looks like a spontaneous
ascites.
perforation.
Yeah.
Spontaneous biliary perforation. PT percutaneous cholangiogram showing spontaneous biliary perforation.
आगे आप चली गई थी जिसकी आपको फिर बुला लिया गया है. Very good.
Okay. Okay.
एकदम नृत्य पहनी है तो good.
Yes. Go ahead. Tell us the features. Your diagnosis is right. Tell us the features.
So another need is for neonatal cholestatic jaundice, sir.
Yeah.
Presents like
So are you telling me this is a percutaneous cholangiogram? What are the identify the places?
Appearing to go through the umbilicus, sir. So good.
Okay, let me tell you. This is the gallbladder.
Yes, sir.
And this is the Foley's bulb. So we have put a Foley. This is a cholecystogram.
Okay, sir.
Cholecystogram. Initially, we've gone in and we have just done a cholecystostomy for the spontaneous biliary perforation. 2 weeks later or 10 days later, we have done this cholecystogram. Now you read the cholecystogram.
Contrast seen entering the gallbladder, cystic duct, and then into the CBD. This apparent leak at the cystic duct CBD junction.
Yes.
The localized collection of the contrast.
So is this the leak or is this the leak?
That is the collection. Lower one is the collected contrast. The upper one is showing the site of leak.
This.
That is the CBD, sir.
That's the CBD, correct, which you can see here. This large thing here is a leak.
Yes, sir.
Okay, fine. So your diagnosis is right. So how? So does the CBD look enlarged to you, or does it look normal to you?
Looks mildly dilated, sir.
Okay. So how do you manage this?
Usually, initially, conservatively with the cholecyst, like drainage from the gallbladder, sir.
Fine. 2 weeks are over. What do you do next? Child is okay, passing yellow colored stool. Abdomen distension has come down. What do you do? You are on the right track. I just want to see how you manage.
If it does not close spontaneously, then might require a hepaticojejunostomy, sir.
Okay, so you wait for 2 weeks and then you
Do
want
contrast
to
studies.
again check. Don't you want to check again whether this
Yes, sir.
leak is there
Contrast.
or not? So you can do a
Repeat
contrast
contrast.
study. Anyway, you have this here.
Yes, sir.
You do a contrast study, and if it is settled, it is fine. So let us say this has settled. The next time we did this, it was settled.
Yes,
So
sir.
is there any other thing that you want to check? Because you said that this is dilated.
Any like bile plugs distally, sir?
But bile plugs distally, isn't there any other way of making that out? In your contrast study 1, how else can you make out whether there are plugs and whether there are obstructions? In a given patient, you
Yes,
are
sir.
thinking of an obstructive cholangiopathy in this child. How do you make that out?
Like in the contrast
Clinically, you
study, sir?
first go, everything starts from clinical. So you say clinically, I will look for pale stools, jaundice, etc. in investigations. Then I
Yes,
will
sir.
do an imaging. So always you start from clinical, then go on to
Clinical.
biochemistry imaging. That's
Yes, sir.
sequence. So in imaging, you can do an imaging, isn't it? To clarify whether this is actually a dilated duct or not, etc.
Yes, an ultrasound would show the
Okay, you can do an ultrasound. You can later do a better imaging like an MRCP.
MRCP. Yes.
Yeah, yeah. So they're just sort of trying to see whether you know systematically how to go from clinical on to investigations. Then you do the screening investigation first, then go on to the confirmatory investigation. So if you straight jump to MRCP, then they will say, why? Don't we have any clinical features?
Yes, sir.
That is why.
Yes.
What yet another way of looking whether there is good drainage or not is what?
HIDA, sir.
Another way of looking whether there is a good drainage or not of the bile is what? Which other
HIDA
investigation?
scan, sir.
Yeah, you can do a HIDA scan. Right. Okay, good. Yeah, this is an easy one. Come on, someone take this. Gaurav. Dipanjan.
Sir, can we do ERCP in previous case?
You should say whether ERCP you can do in this. Remember, this is a 20 days old child. So not easy to do an ERCP. You can do an MRCP probably, but not easy to do an ERCP to cannulate and do. It's quite difficult technically. That is why. In an older child, your options will change. You can probably do an ERCP, but when you have an MRCP without the complication of a cholangitis, you might want to do an MRCP. The time that you choose an ERCP is when you need to put in a stent, etc., and that will be therapeutic. So that is when we take the risk of cholangitis, etc., and do an ERCP. Of course, technically also you must have someone who can do it in a small child, right? So think of those practical things and say logistics and say, yeah. Yes, please. Come on, come on.
Sir, can I take
There are
this?
just one or two more.
This, sir, can I take this, sir?
Sure.
Sir, it's a lower GI contrast study, sir. With the with Foley's hitched to the lower in the rectum, showing intersusception in the ascending colon, sir.
Right. Okay. How would you, of course, they have done this with contrast.
Yes, sir.
Are there other ways of doing this?
Yes, sir. There, you can also use ultrasound guided hydrostatic reduction with saline, sir,
Okay.
or fluoroscopic guided pneumatic reductions.
Air, you can use air also. What is the difference between air and using that hydrostatic reduction with saline? Or even here using this, what is the difference?
Both methods can be used, sir. Ultrasound might require a radiologist support for guidance.
Okay.
This would be more technical, user friendly for pneumatic reduction, sir. Surgeon himself can do
Okay.
easily.
The difference here is with the pneumatic, if you have a perforation,
yes, sir.
The contamination is a trifle less than if you have a contrast inside which can go out, a fluid which can go out. So that is probably the difference. So when you take this, go to the radiology suite and you're doing a pneumatic reduction, how do you prepare yourself and go? You've done pneumatic reductions?
Yes, sir.
So how do you prepare yourself and go? It's a question is very much like the question for that upper GI contrast study.
Yes, sir. We will keep an OT table ready, sir, in case the child requires surgery, and we'll keep a wide bore needle ready in case there is perforation to put the needle and decompress the abdomen.
Right, right. So you'll have resource equipment, especially a wide bore needle, so that should there be a perforation, you can easily
decompress.
Correct. Right. So you do this and it does not reduce.
Yes, sir.
So is there something else you have to keep in readiness? You have to keep the OT as standby.
Yes, sir. Yes, sir.
So that is an important thing that you must say, tell the examiner.
Yes.
Okay. Right. Yes, Supraja.
Sir, this appears to be a distal rectal contrast study taken in oblique position. We can see contrast entering from the rectum into the sigmoid, which appears to be not dilated. Then we can see in the mid-sigmoid level, there's a transition zone and sudden dilatation of the proximal sigmoid. Most likely short segment first trunk disease.
No, dilatation of what?
Of the proximal sigmoid or descending colon.
Achha, this is the descending colon. That's a descending colon. And this is the upper sigmoid. So you think the transition is there in the upper sigmoid?
Yes, sir. Yes, sir.
Okay. So then why are you telling us this is short segment?
Long segment.
Yeah, it is longer than rectosigmoid. Rectosigmoid is there. It's even longer than that, a little longer than that. So it's, yeah.
Long segment.
Right. So which is the commonest form? Commonest transition is
most
found
commonly
where?
we'll see at rectosigmoid junction.
Rectosigmoid transition. So how would you approach this child? This is a 1-year-old child who has this thing and has the usual history. So is on sort of washes and all now. How would you manage this child?
Sir, generally a long segment we would not be able to give washouts and do a primary transgenesis. So I think we should go for a colostomy.
Okay, so if let us say this child, you are right that your washes may not decompress this fellow properly because it is long, but let us say it is decompressing with washes.
Sir, still doing a primary procedure, transanally might be difficult, sir. So we can plan for a Duhamel. Maybe we can do a primary Duhamel or do a colostomy if the proximal bubble is very dilated.
Okay, now you have taken the bait. You said a primary transanal is difficult, but you can do a primary Duhamel. Does that stand to reason? If you do a primary Duhamel also, you will have to accommodate one largish proximal
Dilated
bowel
bowel,
into the pelvis, small pelvis.
Yes.
So not really feasible.
So safer to do a colostomy and then go for
so
a
your line of thinking was correct initially, that it is a large proximal bowel, unlikely that you will be able to, and it's an older child, so unlikely you will be able to do a primary procedure, whether it is this or that. So you may have to do a leveling colostomy and then
Yes.
later do a pull through. That.
Pull through.
Whereas if it was rectosigmoid and not much of a proximal dilatation, you might go ahead with the primary procedure, whatever you choose to do, transcendental endorectal, primary duhamel, etc., after washes. Yeah, so the examiner will give you some scenarios, like I told you here, that we are able to wash out. That
Yes.
is fine. But with the washout, are you with this level and this dilatation, is it going to respond or not? Realistically, you must stop and
Yes.
then justify yourself. The moment you say those things, the examiner knows that you know actually in a given patient what are the parameters you are looking at.
Yes.
Okay. So let us say we do a colostomy in this child, we do a leveling colostomy. How
Yes,
long
sir.
do you wait before you do a pull through? It's a large dilated colon. How long do you generally wait?
So we can wait for 3 months, sir. Generally, we try to do the definitive procedure by 3 months, sir.
So you generally wait for just 3 months in a dilatation. For example, in an ARM, we wait for if you do a stoma, we wait for around 4-5 months, weight gain to happen, etc. and do. So here with this dilatation, you generally wait 3 months or you wait longer?
3 to 6 months we can wait, sir.
So you should say what you reasonably do. Yeah, it is
Okay.
a little longer, 6-7 months. You wait for, particularly this gross dilatation. In some, it may be even a little longer for it to come down.
Yes, sir.
What are the problems if you do a pull through of a large bowel into the pelvis?
It
Let's
will
say you do
prolapse, sir.
duhamel or whatever.
Once it starts to decompress, it will prolapse. So they'll have mucosal prolapse.
Prolapse. Before prolapse, it
And
has to first, in that crowded
function.
space below, it has to first start to function properly.
Function.
So again, problems might be there. Dysmotility problems might be there till it comes down, right? So that is important. Okay, I think this is the last. Yes. Yes, please. Someone take this. Who has not done? Any of the exam going people have not taken this? Gaurav has not spoken today. Gaurav, are you there? I don't think he's there. Bhanu, are you there? Dipanjan?
Yes, sir. Hello. Am I
Yes.
audible?
Yes, you are. You are who?
Sir, Dipanjan, sir.
Yes, Dipanjan, please.
Sir, this is the contrast study taken in of the abdomen and the pelvis taken in an oblique view, where we can see that through a Foley's, the dye has been instilled into a loop of bowel. Probably this is the distal sigmoid colon, and the dye is filling up the lower pouch, and it is also entering into the urethra and also filling the bladder retrogradely. So this is a pressure augmented distal lupogram in the case of ARM.
Yeah. So what are your observations on this anatomy? How will it influence your treatment planning? You do the study to help you in your surgical procedure, no? So how is this going to influence your treatment planning?
So in this film, we will have to observe for the length of the distal limb and also the level and the lowermost level and the beaking, and also if there is any filling in the urethra or the bladder, if there is presence of any fistula, and the relation with the sacral vertebra at the level, sir.
So you tell me. I will tell you one thing, that I think this tube has gone a little too much inside. This Foley's bulb is inside, and I really don't know how much more proximal bowel is there, because here this is only a sacral hollow thing, And
sir.
I cannot see a big fecaloma there, but if it is overfilled, maybe the fecaloma is hiding. So I would need to see more films. So much I will say. Now you tell me more than this. Can you approach this surgery through the PSRP or you need an abdominoperineal?
Sir, it is the lower pouch is coming below the coccyx, sir. It will
Correct.
be
So below the
able-
bony thing, so you can approach through PSRP. So that's
Yes,
the
sir.
next point. Third,
Yes.
something
Third,
about this.
there is a fistula in the sir bulbomembranous junction probably.
Okay, there is a fistula there in
Yes.
the thing, but what about the fistula? Is it so do you anticipate any problem in the OT with this?
Sir, there might be problems while catheterizing the bladder, sir.
Yes, so catheterizing might be a problem because in the line it will go into the rectum. So you might
Yes.
have a difficulty in catheterizing. You might have to use a cystoscope and other maneuvers so that you have a catheter going there. And there's a sharp angulation. So again, your dissection there, it has to be important. And it is low down.
Yes, sir.
It is low down, so your common wall is so much for you to dissect. So it will be easy to get to the fistula, but there will be a long wall to dissect, right? So
Yes.
these are the things that you look for in a distal cologram. Fine.
Yes.
So you have done this surgery, and during the surgery, you have an injury to the urethra here, intraoperative. So how do you manage this child?
Sir, we will have to repair the injury over a Foley's catheter, and we'll have to
Right,
keep
there's a Foley's catheter you have put. How do you repair the injury? Any technical points?
Sir, we'll have to place some intervening tissue between the rectum and the urethra repair, sir. After
Okay, that you will do. When you close the urethra, is there anything that you are careful about? The way you close it?
So the bite should not include the Foley's catheter.
Okay, fine. That's one. You close it transversely rather than longitudinally to avoid a narrowing.
Okay.
So you try to close it transversely so that you avoid interrupted sutures. Yes. And then you use something interpose in between, like you were saying. Avoid taking the catheter there, and then do as many layers there so that it gives you a good separation and it doesn't refistulate. Then post-op care.
Post-op care, sir, the Foley's catheter should be, sir, in situ at least for 2 weeks, sir.
Okay. Right?
Yes, sir.
Then after 2 weeks, do you pull it out or do you do some dye study, anything? Your unit practices?
Sir, usually we remove the catheter and see if there is
okay.
child is
Fine. Or
passing.
you might do a contrast study and take it out. Both are acceptable depending on how the post-op course has been.
Yes.
Okay. Fine. So we will stop with that today. So I hope with this you had an idea where your questions can go depending on how you answer. And so this is just a launch pad to start off the questions and go in different directions. Right. Any comments? I can see Dr. Archana is also there. Sir was there. Dr. Bagdi was there. Okay. If there are no other questions, we will stop. Thank you.
In the last instance, when you have a urethral injury, is it safer to do an SPC? Over, is it meeting?